Welcome to Shine Together, a podcast where Edmonton's brightest minds come together to share ideas, collaborate, and inspire. What makes a city great is its people, and this podcast is all about bringing them together. So let's dive into meaningful conversations and make our city shine greater together.
Need to go. All right. Thank you for being on the show, gentlemen. I'm Dr. Omar Mohammad, and I'm running for mayor in the next municipal election here in Edmonton, Alberta. Welcome to Shine Together, an Edmonton podcast where one expert Edmontonian takes the host chair and the other expert Edmontonian takes the guest chair. And I get the honor, privilege of witnessing, listening, learning, and growing alongside both of you. Our guest today is Tony Korobanik, a true frontline hero and one of Edmonton's most seasoned advanced care paramedics. With over 25 years of experience in emergency medicine, Tony has worked at the highest levels of care, including critical care, transport, and air medevacs. He's seen it all, from high-stakes rescues in the field to life-saving interventions in clinical settings. For more than 2 decades, he's been serving the people of Edmonton through EMS with unwavering dedication and heart. But Tony doesn't just save lives. He also shapes the future of emergency care. As a lead educator in emergency medicine, he teaches essential regulatory courses like ACLS, PALS, BLS, and airway management. He's taught at top colleges and institutions, mentoring the next generation of healthcare professionals and sharing his deep knowledge with learners at every level. From paramedic to professor, Tony is a force in the world of emergency care, and we're honored to have him on the show. Welcome, Tony, to the show.
Wow, thank you. That was quite the intro.
Awesome.
And it's a true honor to introduce our host today, someone I've had the privilege of knowing for over 30 years, Dr. Alexander Ye.
Since I was a baby.
Dr. Ye is a full-time general dentist with nearly 2 decades of clinical experience and the founder and principal dentist of Smiles Dental Group, Edmonton's largest branded, locally owned dental practice. Since 2008, Smiles has proudly delivered quality and affordable dental care to over 250,000 patients across our city and region. Recognized as one of Edmonton's top 40 under 40, Dr. Ye is not only a leader in healthcare, but also a passionate philanthropist. He's donated generously to a wide range of local causes, always giving back to the community he serves. He's a respected entrepreneur, a dedicated professional, and I'm proud and honored to say a lifelong brother and friend. Welcome, Dr. Alexander Ye, to the show, and thank you very much for being here today, gentlemen. I hope we shine brighter together. And Dr. Alexander Ye, the show is all yours.
Well, thanks for that introduction, Omar. I remember it was 30 years ago we met. Do you remember where we met?
We met at the Convention Inn. We were bus
banquet waiters.
Banquet waiters. That's it.
Banquet waiters.
Yeah, high school.
Yeah. Wow. I remember what were we making? What was minimum wage? Like $6 an hour back then?
$4.25 an hour is what I was
my
making
God.
at that time.
I still
I
am.
think I got a raise to $5 eventually. Yeah.
Oh man. Yeah. So Tony, I know Tony because his company offers a service for our dental clinics, which provides emergency kits, as well as he does all our CPR training for our staff and associates. And he's just been terrific, amazing to work with. And as impressive as he sounds on paper, he's even more impressive in real life because, you know, this guy is like one of the most hardworking people that I know, and I know a lot of hardworking people. And he essentially, like, he basically saves lives every single day, and that's what his job is. And I wanted to ask you, Tony, did you want to maybe start with an anecdotal story, maybe, or tell us something that's happened to you recently that might be of interest to the listeners?
Yeah, it's that's quite the intro. Thank you. I feel like I could leave now. It's it is a privilege to work in kind of the first responder field. It's definitely got pluses and minuses for sure. I think on a daily or per shift level, we sometimes forget that the things we do and are exposed to in our normal job are things that sometimes people might not see their entire life. And so it's always interesting to kind of, pick stories to share. You'd never really know what would be, sometimes an appropriate story, right? Because not everyone is in the industry and shares the same mentation, right? And the same viewpoint. So it's been a long career with a lot of ups and downs. I think, the highlights definitely are when you get to finish a call and leave a patient and know that your time with them has been of benefit, right?
Yeah.
And it's not always, some life-saving medication or intervention. Sometimes it's just a conversation, right? It's taking time for someone who maybe no one's taken time for,
Yeah.
right? And today's, situation and climate and the way, Edmonton's having its struggles, I think there's a lot of people out there who people just aren't taking time for.
Yeah.
And so on a day-to-day, we get to interact with these people, and sometimes it can be challenging and it can be overwhelming. But, to hear you ask for, an anecdote, it just makes me think that, our job isn't always, the life-saving, interesting stories and the grit, right? It's sometimes just having a conversation with, the houseless guy who has a story you wouldn't believe, right? And so I'd almost rather, share, one of those stories, for example, right? Like, when I work, I end up working downtown a lot. And so I interact with a lot of different, houseless individuals downtown. And the idea that they're there, by choice, definitely there's choices, right? And they have consequences, and people have ended up sometimes where they are because of those. But once you're in the middle of it, it's hard to get out. And there's, one individual that I think of all the time, because it could be any one of us, was a successful, owned a construction company, had a family, worked hard, right? Like, someone who you would never expect to have challenges in life, but we all do. And he ended up making a few bad choices, started with an impaired charge, lost his license. And right, an absolute bad choice and a well-deserved consequence. But as a result, he lost some contracts at work. Money became tight. He had met some friends who didn't make the best choices either in the recreational activities. Ended up trying some illicit substances, some drugs, some cocaine, which quickly led into an addiction.
Right.
And now he went from going on holidays with his family to living outside the Hope, having a fire with whatever cardboard he can find. And it's not something you ever think when you drive around downtown and you see these people, or they're crossing the street in front of you, on a red, and you're late and you're irritated, and, it's frustrating, and they impact a lot of areas of life in the downtown area. And we don't realize sometimes that a lot of them have a story that started where we are now.
Right. Well, Edmonton's facing an unprecedented opioid crisis. I mean, I pulled out a statistic where EMS responded to 154 opioid overdoses in just 1 week, just in this February. Now, this isn't just a statistic. This is, as far as I'm concerned, a public health emergency. Now, somebody who works in the front lines, can you tell me a little bit about how that changes affects your day-to-day and your mental health and your mental health and well-being?
Yeah, there's a loaded question. So to give it some context, I guess, in the first 15 years of my career in EMS, I administered naloxone maybe 10 times, maybe.
And naloxone, just to our listeners,
that would be the life-saving medication to counteract opiates.
Right.
Right. So you can go to your pharmacy and get a free naloxone kit now. They hand it out for free. It's so popular. we've never had opiate, an opiate problem in Edmonton. We were more of like a meth and cocaine city, right? And, when we did administer Narcan, it was usually to grandma who, took her Percocets and forgot she took them and took some more, right? And it was such a shift in practice to go from giving a medication, maybe once a year to giving it 10 times a shift or more. You can work a shift in the downtown area and do almost nothing but overdoses. You can do 10 and 12 hours. Sometimes.
It's become a regular rigmarole. So back in the day, there was hardly you would administer naloxone, Narcan, and now you're finding that it's just, you're doing about 10 a shift is what you're saying.
Yeah, more in one shift than in 15 years before this opioid epidemic.
What percentage of your calls would you say are related to this problem now?
I guess I can't speak for the system overall. Yeah. I work, mostly I pick up shifts in the single member response unit. It's called PRU. And so I can't really say kind of what the ambulances are seeing, but just from talking with crews and from seeing multiple crews in the same shift doing overdoses together multiple times, they're experiencing the same thing, right? And the job is the job and you respond to the calls in front of you, but the resources aren't increasing to meet this extra demand, right? And that's the problem is when you try and, staff a service and you try and use statistics based off of, healthcare data and all those kinds of things. I'm not a statistician, but I think that we're missing something because the call volume in the downtown core alone could handle a whole service by itself. Right. And so our ability to respond to other emergencies is being impacted quite drastically due to the use of resources. Right. And so, it's been a struggle, right? It's been a real struggle. I think the issue that we face sometimes day to day isn't so much responding to these overdoses. It's that we're required to sometimes turn away from or respond away from other events, right?
Right. Yeah, I hear like if you say you have a heart attack, so you get a call for a heart attack or a suspected heart attack, and you get a call for an opioid overdose. I've heard that in talking to paramedics that now you have to respond to the opioid overdose over the heart attack. Can you comment a little bit about that? And
so. Edmonton, as a lot of North American cities, it uses a dispatch system. I think it's ProQ or something. I can't remember what it's called exactly, but it's a system where the dispatchers are required to ask certain questions, and then based off the caller's response, they then are directed to the next question. And it's a very step-by-step robotic system they're required to follow. And then that gives the result of the call type and the required response type, whether it's lights and sirens or we get there when we can get there kind of thing. And so when these calls are being evaluated, the call evaluator isn't really allowed to use, I don't want to say common sense because that doesn't sound good, but they're required to dispatch the call as it comes in.
Right. Okay. So there's
regardless of outside thought, experience, right, understanding, they're required to dispatch the event as it is coded through this mandated system of questions.
Right. So that's true. So my understanding is that you have to respond to an opioid crisis, even though you might be on your way in attending a heart attack situation. You often get turned around dealing with an opioid crisis based on how they're categorized in terms of triage for yourself.
Exactly, yeah. Because that dispatch system, some of the important questions are they conscious, are they breathing, right? And so if you're having a heart attack, unfortunately for you in this system, you are conscious and breathing. And the overdose patient is not conscious and breathing. So that becomes a higher priority response event. And so the unit would automatically be, the closest unit would have to be attached depending on the number of units available. And so we are directed away from a response we could be on to turn and respond to one of these higher priority overdoses.
Absolutely. So this is one of the ways this opioid crisis is actually affecting, laterally people that don't make those decisions.
Right. Yeah.
To use hard drugs. Yeah.
And it's got nothing to do with who deserves an ambulance more, right? Because that's not a debate, right? It's everyone needs an ambulance. Yeah. It's just the resources can't support both. Downtown, we have a lot of groups and agencies that are helping with this opioid crisis. Right. Boots on the ground, Reach, right? A lot of great organizations. Yeah, the Hope Mission has nurses and medics that work on staff and respond immediately to these events. They're usually the ones calling it in. And so we'll have a nurse who's effectively treating this patient just as well as we are, calling the call in, and it will still come in coded as a high priority event. So someone who has no help on scene doesn't get an ambulance, and we're going to someone who has a nurse there, right? And so, again, it's just, it's simply my viewpoint on it, my outlook on it, right? I want to continue working for AHS, please. So I'm in no way, representing AHS. It's just my personal lived experience out there
just
on the
opinion.
street.
And we all have, we're all human. We all got pulls one way or another.
It
puts you in an internal conflict of, maybe having to respond to an opioid crisis when somebody's having a heart attack or a stroke or something else.
And they have help.
And
they
have
That's
help.
the key.
Yeah.
If there's no one there helping, right? I mean, if someone's not breathing, they need help. You got to get there, right? And that's not the thing. It's that you right in the event itself, it's stated that there's someone there helping, right? And so it does create a sense of frustration sometimes.
Sounds like it sounds like the solution. I mean, there's no easy solution, but one of the changes that could be made is that algorithm that you're talking about, the existing system that determines where the ambulance goes, could be changed for the better, right? Like if there's a nurse on scene that can be administering Narcan to an overdose, that needs to be accounted for in the system where it allows you as an ambulance operator to go to the person now that's having a stroke or heart attack, as you're saying, right?
Right, yeah.
The other shocking thing that would contribute to the solution as well, it was something that you mentioned before and I found shocking, was that there's the same number of ambulances now in 2025 as there were in 2005. That's 20 years of growth that in the city of Edmonton that has not been accounted for.
And I mean, the reality of it is, on paper, they've added trucks, right?
Right.
When we're fully staffed and everyone shows up to work, we still don't have enough resources, but we do have more. So there has been growth on paper. The problem is, and don't take me to task on these numbers, but I'm fairly confident they're accurate, that 30% of our staff are currently off, right? On injury, disability, mental health.
Mm-hmm.
Yeah.
And
so it effectively reduces.
It reduces. So for example, the other day with the people that actually showed up to work, we had as many ambulances on the road as we did in 2005, right? And so we were supposed to have more, right? There's on paper, there's more trucks. We just need people to work in them. Right. And that's the struggle is finding people. Right now, just about 50% of the staff have less than 5 years experience out on the road, right? Because people aren't staying in this industry.
Yeah, you can see how it would be a high, I always talk about burnout in any field, any career, whatnot. The average, they say among dentistry is about 10 or 12, and that's my career until you start maybe experiencing burnout. But talking to paramedics, it seems to be there's a lot of turnover in your field. A lot of stress, a lot of anxiety, a lot of mental health, a lot of, you needing days off, and you can almost expect why intuitively.
The job itself is inherently stressful, right? But we're trained for that, right? We do a lot of training and mentally you do build resiliency around those events, right? It's a lot easier to be in a stressful event when you have the resources to deal with it, right? And even if that's just on a specific call, right? You have a sick patient you've got the training, the education, you have the medication, the tools to try and help and intervene with that patient.
Mm-hmm.
So although the event is stressful, you're doing something about it, right?
Well,
And so I think a lot of the stress that we're experiencing, I'm not a psychiatrist, but I think a lot of the stress is this system is putting us in these positions where we don't feel like we're cared for by management.
mm-hmm.
Our needs as employees aren't being met. We're being put in positions that aren't safe. We're responding to call volumes we've never experienced with less staff than we've ever had. And we can't control those factors, right? So these stressors we can't fix, right? And we're fixers.
It's a sense of helplessness.
It's a sense of helplessness and frustration, right? And so I think then your cup is so full of stress from just dealing with the ridiculousness of everyday EMS system nowadays.
Yeah.
And then you go to this call that normally wouldn't be as stressful, and it's enough to tip the bucket.
Well, that's right. Safety, EMS and safety, the ones saving our lives. Safety is an issue. I've talked to some paramedics. You guys are walking in, you don't have backup, you don't carry weapons. You're walking into situations where, unsafe situations, unpredictable situations. It's one of the things, as mayor that I aim to help out with, with backing up and response with the EMS and the Edmonton police and coordination with mental health supports. Because if we're not protecting the ones that are saving our lives, what kind of city are we building? I mean, so that's something that I'm really aiming for in terms of coordination. I do see a disconnect there. You guys seem a little bit on your own, and with all your training and that sort of thing, you're able to get through and get to your rigmarole. But I feel, just outside looking in, that we can do better as a city to help the support, even though EMS is under the umbrella of AHS. Yeah,
I know, and I love that sentiment. I think those of us who were in EMS prior to AHS taking over in 2009, 2010, you ask any one of us, and working for the city of Edmonton was great. Sometimes we didn't realize it at the time, but we had resources, we had supports. If we needed training in something, it was a lot more accessible.
Mm-hmm.
Now, to get through the layers of management, right, in a provincial government-based system, it's like it exists to create layers, right? And so where with the city of Edmonton, if I remember correctly, I think on shift, we might have 3 or 4 supervisors on per shift back then, because we worked pretty independent as medics for the most part. And now we've probably got 12, 13 or more, and supervisors, management, and I struggle to see the difference in EMS, right? It's still the same job, right? And so one thing that AHS was successful in doing was creating some pretty good management positions, right?
Right.
And but you would think that might facilitate getting things done, but in the city of Edmonton days, for example, when you talk about safety, we had access to self-defense training, right? They would put us through self-defense training programs. And it was just another extra tool that we could maybe access if the need arose.
Right.
Like you were saying, as medics, we're pretty good at getting it done. We develop a way of talking ourselves out of a lot of problems, right? That's our best tool, right?
Right.
And you get a pretty good sixth sense of where you want to go and where you don't, right? So safety, starts with not even getting out of the truck sometimes. But we get into situations that we can't always predict, right? And so having a little bit of experience in how to protect yourself physically can be important. And AHS has, we have it's called nonviolent crisis intervention. We have to do every 2 years. And it's a program based around dealing more with like a dementia patient, who's 90 years old and grabs your arm. Right. And so you gently tap and say, please let go, or, you know what I mean?
Yeah.
And there's, maybe 3 minutes dedicated to, if someone grabs your hair or some basic things that don't equal any type of safety training for us. And so to request something like that, right?
Mhm.
I've heard some of the fear is if they teach us how to defend ourselves that we're going to start
Defending
using
yourself.
it, right?
Defending
Yeah,
yourself.
Like,
gonna have
yeah,
to
it's going to be kung
defend
fu in the
yourself.
ambulance,
Yeah.
right?
Well, here's the thing.
And that creates liability for the system, right? And they're all about avoidance of
Well,
liability.
avoidance and liability, but let's look at the human cost of things. I mean, we're all in healthcare at different degrees here. I mean, I've been swung at once after I pulled out a wisdom tooth. And that was a big event for me, like
Right.
to have a patient swing at me. And that was like I've been doing this since 2009. I don't know if you've ever had an attack at you, maybe verbal, like we get that, in
Yeah.
our field.
Yeah.
But, I couldn't imagine my job, trying to, provide service to people and try to help people, and they're attacking me, right? So back to like trying to coordinate, and my aim as mayor would be to coordinate EMS along with security and Edmonton police, as well as mental health supports. I think it's paramount, especially in the opioid crisis that we're facing.
Yes.
Sir, and you're talking about just wanting to have self-defense as now it's just a normal thing. I mean, how often would you say you get attacked in your job?
So I guess there's different levels of attacked, I suppose, right?
Mhm.
You're talking about being verbally attacked. That's on a daily basis.
Yeah.
Daily we're verbally, assaulted and threatened and swore at, and that's kind of just water off our backs at this point for the most part, right? Whether it should be or it shouldn't, right? I know, HS has these signs that no verbal abuse will be tolerated, right? Well, I'll get in an ambulance, right? Like,
Yeah.
and so we're very good at just deflecting and de-escalating and those kinds of things. So daily we are verbally attacked and assaulted. Physically, it is becoming more and more common. And I don't know if it's just related to, things going on in society, a lack of respect for uniforms or authority. I was at a fast food restaurant a couple of months ago, maybe a little bit longer. Anyway, and an employee didn't feel comfortable serving me because of my uniform, and so they left the till, and the manager had to come and apologize that the employee didn't feel comfortable serving me because I was in a uniform. I'm a paramedic.
That's a different one. Yeah.
Right. And so we've created this culture today where anyone in uniform is a target, right?
Right.
It's so anti-authority nowadays. There's no respect. And that's filtering right down to the EMS level, where I think if you ask any medic, we've probably never felt more unsafe. On a personal level, I was just attacked a little over a month ago, doing an emergency response on White Ave, and an intoxicated patient, and there was intoxicated family that showed up, and it just escalated to the point where when I exited the ambulance, I work, like I was saying, in a separate SUV.
Mhm.
The patient was safe being cared for in the ambulance. And so I exited to go back to my unit, and the family member and a couple of the friends of this family member who didn't think we were concerned enough for the patient, and they were all intoxicated, ended up attacking me, and it became quite the ordeal. I was punched, I was kicked in the head, got put in a chokehold. This is on White Ave.
Yeah,
Right.
sounds like a pretty
And
serious physical altercation.
It could have gone very bad
Yeah.
if, fortunately, it was an off-duty, I believe it was transit security or peace officer, stopped. So I was basically in this chokehold, trying to get some space to take a breath, trying to block myself from being kicked in the head, and I heard brakes squeal, and then some shouting, and the person ended up, I let go. And so someone had stopped to help. Otherwise, I don't know how it could have ended up.
That was your backup,
Right?
Back to the coordination.
Yeah.
It's a real deal. And I'll give you another staggering number that stopped me in my tracks, and that's 207. And back to the naloxone, the administrations, that was the number of naloxone administrations given on Edmonton transit systems, public property, by commissioners, by security guards. It's become a security issue. That's in the first 2 months of 2025. And just to give you a kind of statistics, that's almost half of all of 2024. We're seeing a really big uptick here as of late. And I'm sure you've had to respond to some of those. Security is no longer about vandalism or fare evading. It's become a spot where people are using a lot of drugs, and security is becoming an issue.
Yeah.
Do you see that in your profession? And have you had to respond at all?
Yeah, we interact a lot with security, EPS, peace officers, transit, and then all your private security groups, commissionaires, Palisade, those ones. There's some interesting, excuse me. There's some interesting policies with some of these companies where some of these private security companies are not allowed to administer naloxone. And I was mind blown. We're having this argument street side. I'm like, what do you mean you can't give Narcan, naloxone? And they're like, yeah, we're not allowed. One guy actually said I would get fired if I gave it.
It's got to be a liability.
100% it's a liability issue, right? When you as a private citizen can go to a pharmacy, get a naloxone kit for free and give it to anyone you want, right? But someone who's supposedly in a position of safety and security, who is going to interact with these people more commonly than, an individual on the street would, is prohibited from administering naloxone. Man, I found that really surprising.
These are private security people?
Yeah. So whether they're,
bizarre.
whether they're contracted to, different agencies, organizations around the city, I don't know in what role, but as a private company, they are not allowed to administer Narcan.
They must have taken some legal advice on that.
I would imagine that's exactly what happened, right? Some are only allowed to administer the nasal spray, right? They're not allowed to inject. Well, the nasal's got a bit of a shortage, right? So you can't really find that much. So if there's no nasal, there's needle everywhere because you can get that from the pharmacy, but they're not allowed to administer those. And so I think some companies need to start examining some of their policies a little bit and maybe getting some good legal advice around whether you are, better to administer, and save someone's life.
Right.
The needle system is very safe. It has a retractable needle. So after you administer it, the needle's gone. Right. So the risk of poking yourself after is zero if you do it properly.
Yeah.
Right.
I think the problem is there's no legal challenge. There's no problem with you having any liability if you do nothing, because you cannot compel anybody to do anything. Right. So you're safe to do nothing, but is it really the right thing to do? No, it's never doing nothing is never the right thing to do when somebody's dying.
Not in the role when you've chosen to go work as a security officer.
Right.
If you're out for dinner with your wife walking down the street and someone's overdosed, I totally understand maybe not choosing to maybe wake this person up who could potentially become violent, or someone misinterprets what you're doing, right? But that creates some safety issues, even for us sometimes. And so we do consider who, what, and where, and how much we wake up and how much we administer, right? As long as we're breathing for you, you're alive and well, right? And so sometimes we will titrate our dosing so that we can safely rouse someone in the ambulance or when there's less people around, or right? So we make those choices. But I could understand, as a private citizen, maybe choosing to call 911, and not feeling comfortable or safe to administer Narcan. I could maybe give them that. But as a security officer, when you're choosing to go out and put even any type of uniform on and interact with people, that I think should be kind of part of your job, right? But yeah, it's to get back to kind of what you were saying around, coordination of resources and stuff. Every city service is so strapped. Right, EPS is tight for people. Their response margins are really thin too. Right, we're waiting for police response like everyone sometimes. Right, to get the help that we require.
Right.
If we do call for emergency help, we usually get that in a pretty timely fashion, which is good.
Yeah, good. Yeah.
But like everyone, we spend a lot of time waiting for resources from police for other things. Right. And so again, it just comes back to available resources.
Right.
Edmonton Fire has been, very helpful in helping to manage this.
Right.
They're a fire department by nature, right? And I think medical response has become kind of an ingrained part of their expectation as well.
Yeah, and you often see a firefighter responding. Yeah.
They've got, more money, right? More members, more stations. They can get to a call long before us. right? And so they are able to, in certain situations, intervene and help.
Right.
Ultimately, nothing will ever replace a paramedic responding to your side, right?
That's right.
And so that should be the ultimate goal. Isn't bridging the gap, right? Isn't band-aiding the solution, isn't getting someone who can do something for you there.
Right.
It's getting the advanced care that everyone in this province has paid for and expects and has been promised to their side within 12 minutes. That's the national standard. It used to be 8, right? You'd have an ambulance
in the other
within
direction.
8 minutes. I believe 90% of the time was like the national standard. And then when they weren't meeting it, became 9 minutes, then 11. I think now we're at 12 minutes. And we're not even meeting that. Right. So they're just going to move that target again.
Well, so my understanding here, since 2005 till now, we really haven't grown as an organization for EMSs. And it's sounding that we're having a personnel problem. Is it more of would you say it's well funded by the province though? It's just more of a personnel problem, or is it kind of a mix of both?
I couldn't comfortably speak on the budget side of things.
That's fair. Yep.
Based off what I hear, no, right? We're not. I can comfortably tell you we've been without a pay raise at EMS for I think 9 years.
9 years.
We're in contract negotiations now. The province, I think, has offered like a wage freeze. We're now the lowest paid EMS service from Ontario West out of all the EMS services here in Alberta.
All right.
We're the lowest paid. Of all the first responder services, police, fire, EMS, we're the lowest paid. I mean, we all work together to do the same job, and we all have our areas of expertise, right? And I don't want to do fire's job, and and police don't want to do ours. But when you look at EMS and our training, we're the highest trained. Right? We have years of training by the time we're at the advanced care level.
Okay.
We're doing skills only a physician can do in the emergency department in the back of an ambulance. If you experience a cardiac arrest, for example, we will treat you in your basement or living room just as they would in emerge. We won't even transport you unless we get your pulse back, because we will do everything the emergency department will do.
Right.
And so we have this advanced level of care and accountability, and we're the lowest paid.
And then you're the lowest paid.
Right. And so that stings a little bit, right? I mean, we don't
feel good.
do the job for the pay. I mean, we do, right? We're not volunteers.
It's part of the equation.
We need to live.
It's part of the equation.
Yeah, exactly. But when I chose paramedic, I didn't look at the wage and say, "Oh, here's a good paying job." Right. I chose paramedic because I wanted to do it, and
it's thankless. It's thankless, right? Like, and that's one of the big problems for trying to attract new talent to the profession, right? Like, who wants to go? Like, I mean, it just sounds like a job that is grueling. Although it's fulfilling, right? Because you are helping people, but there's certain times where you feel helpless, where decisions are being made for you, that, you don't really necessarily believe in, right? Like, I mean, when you have to make a decision on which call to go to, like the heart attack or the overdose situation, and you go to the one and then the other one has a negative outcome or dies, right? And then, you go home with that. And, on top of that, you guys haven't gotten a raise in 9 years. So to me, this is a huge barrier for people wanting to become, an EMS, paramedic. And now, because there's a shortage of you guys, and also you're burning out because of all your overtime and the negative experiences you have at work. We're having to rely on plan B, which is firefighters who are doing a great job, but that really is what it should be. It should be plan B, not plan A, where firefighters show up to like a medical emergency. That just can't be the norm. You know what I mean?
Yeah, absolutely. And we do rely on them a lot for help, right? They're an amazing resource for being able to provide care. And it's, but there's a cost involved too, right?
Yeah.
Getting all those resources to see.
Put no fires, right? That should be a plan B, just like Dr.
Right?
EA is saying.
Yeah.
It's becoming kind of the norm now.
So they tried a system where if we needed help moving a patient or something along those lines, a large patient or difficult extrication from a home, where we would always call for fire, right? Because you'll get a group of individuals, right, who can help you move this patient. And then they said, well, no, we're going to call for an ambulance to help first, okay? And we're like, hey, that's good, right? Because now we can adequately reflect the resources we're using for EMS.
Right.
But we never have another ambulance available.
Yeah.
And so when we have no ambulances, then we're allowed to get a fire truck. So we end up getting fire trucks anyway because we never have ambulances available to come help when you need help from another unit, right? And so we're right back to relying on them to fill the gap for us, right? And they're feeling it too, right? They're overworked as well. You know, as these downtown pumps, their call volume is as much as ours. They will do more overdoses in a shift than they'll do any fire-related events.
Yeah.
You know, and that's not what they signed on for, right?
No. Yeah.
And
you know,
so we need to, Dr. Ian Blanchard did a study on our dispatch system. And I mean, it's wholly ineffective when the whole system is based off fear of liability, right? So what could possibly be wrong with this patient? Well, there's a 1% chance that this patient is having this event. So then we respond to that worst case scenario. Ambulance, paramedic response unit, fire truck, 3 units showing up, and this patient has been feeling unwell for 10 days. You know, but because the dispatch system is so liability heavy, you can't say logically, you know what, sir, we'll get an ambulance to you when we can, because they say keywords like, you know, shortness of breath, but they're speaking in full sentences on the phone. You know what I mean? So until we're able to, like, logically and without fear of litigation for the dispatch response system, send appropriate resources, we're forever going to be sending
too much
to all these events. Right?
To certain events where other events are needing it at the time.
100%.
And so
that's exactly so.
Disparity.
Yeah, it's a whole system of problems, right? That really comes down to, I think at the end of the day, what needs to happen first on some level is we need to get ambulances on the road and staff in them, right? And when we can adequately respond to the calls safely and effectively, then we can start mitigating maybe, you know, how we respond to calls or what the best resource is for these calls, mental health responses, right? Overdose team responses, those kinds of things. But right now we need to make sure we have paramedics showing up to work, getting in those trucks and responding to your calls for help.
So my understanding then is, you know, a couple things are kind of shorting you guys on the work here, because you're kind of being dispatched to places where maybe there's already help. You haven't had a pay raise in 9 years, which is maybe not attracting some new contenders to the EMT department. And, you know, at the same time, you know, we've got an opioid crisis that we never had. So you guys are kind of getting hit from multiple angles.
Yeah.
And here's another one. Me and Dr. Ye have been talking about this one lately, is the new public spaces bylaw that's going to be coming in.
Right.
So $500 fine for public urination. You'll get a $250 fine for littering. But yet you'll get a $25 fine for using fentanyl on the sidewalk or at a bus stop. Now, for me, what that likely will do is going to be pushing fentanyl use from the bus stops to the back alleys, or from maybe more public spaces to, you know, the darker corners. Now, in your job, you know, if people aren't seen, especially with overdoses and that sort of thing, how does that help or not help your job?
Well, I mean, it creates a few extra problems. I think at the end of the day, people have to be found when they've overdosed, right? And lots of the calls that come in are drive-by callers, walk-by callers, people who are too afraid to assess this patient, but they see them and are concerned, right? And so they have to be found, you know? And so if we are, you know, pushing them into these alleys and these corners, you know, it creates an extra level of risk for them that they will overdose and not be found in time to be resuscitated, right? And so, I mean, enforcement I don't think is the long-term solution anyway. Whether it's $25 or $25,000, they're not paying it, right? And they're going to get another one, and eventually it's going to go to a warrant. And then they're going to get arrested and put in jail for 30 days and stay of the fine. And then they're going to come back out and the process is going to start over again. But we cost the justice system how many thousands to have a court date, to put them into jail, to house them, and right back out they go, right? So I think history and other cities and systems have shown that enforcement isn't a long-term solution.
No.
It's a necessary part to ensure that people are safe, right? I think we all deserve a city we can comfortably and safely walk around in and feel proud of, right? And go for dinner downtown with your family if you want,
Of course, yes.
right? I don't want my kids having to step over people overdosing on sidewalks. It's not a conversation I want to have with them, right? And so downtown is feeling it. Staple businesses are closing, going out of business because no one wants to go downtown,
Right.
right?
Yeah.
So enforcement, what's that going to do? You know what I mean?
Yeah, I think we need to work a little more upstream.
Yeah.
It's not a matter of trying to put out the fires that way. We got to look at mental health. We got to look at addictions. We need, let's call it. A lot of that is in our homeless situation. How do you fix homelessness? Well, you build homes, but it's not as simple as that.
Yeah.
You need full wraparound service, mental health supports, addiction supports. Dignity is a big thing. You can't just put people in a big warehouse neither. We do have real answers that actually cost us a lot less in the long run. In so many respects, but thank you very much, sir, for commenting on that.
Yeah. This bylaw, like many bylaws, doesn't address the problem. It clearly is meant to just try to hide the addictions problem, right? They're trying to make the fine more affordable so that people have to pay the $25, and then that's a meaningful deterrent, but it's not really, like Tony was saying, and if it is, it's basically just going to push people outside of these public spaces and into these like kind of darker corners where they are not going to be found when they eventually overdose. And so you're not going to have like overdose problems, you're going to have like dead body problems, right?
To give a little perspective, I'm not a policy expert by any means, so
Sure.
I don't even feel adequate to really comment, on big long-term solutions. I don't know. I'm just a medic and I go see this stuff every day. And what I can tell you is that when someone makes the choice day in and day out, multiple times a day, to put a drug into their system that could kill them every single time.
Yeah.
The fentanyl is unregulated. The dosing is so variable. We have some days where it takes 2 or 3 times as much naloxone to rouse someone and save their life as other days, but it's the same amount of drug that they're smoking.
Yeah.
So when you can sit there and take this little brown sugary looking crumble and say, this one might kill me today, but you do it anyway.
Yeah.
You're telling me a $25 fine is going to change anything about my life.
And that's a great way to put it because, and you're finding, and I was talking to you a little bit earlier, and you find that people will do this multiple times a day. Are you finding that you get frequent flyers that people that you quite often have to?
Absolutely. Yes. Multiple times in a day.
Well, then that leads me.
Respond. People have walked out of the hospital and overdosed at the transit station when they left the hospital from their previous overdose.
Right.
So this isn't these, again, people have all their opinions, and, at the end of the day, it may have been a choice or two that led them to where they are, but it's not a choice to stay there right now.
Right.
And that means they need help.
All right. So back to that discussion of help. And we've talked about this, me and Dr. Ye. It's forced rehabilitations. Now, this is a hot topic amongst a lot of outreach groups. Is that a thing? Do you give people the personal choice or do you decriminalize drugs to some extent, or do you make it more criminal and do you do forced rehabilitations? Do you think that would be the answer? Or
the only thing I can think of is just to compare it. So if we compare it to other mental health issues, if you're in a mental health crisis, for example, in my career, and I know a lot of my cohorts have also responded to patients in significant mental health crisis. It's a staple EMS call, right? All the time. Various levels of crisis, from, not wanting to come out of their bedroom for days to running down the white mud naked, right? There's all levels of crisis. But at the end of the day, they're experiencing a mental health crisis. So when you're running naked down the white mud and we show up, I'm not asking you if you'd like to go to the hospital today.
Right.
You've demonstrated you are not able to make decisions for yourself that are safe.
Right.
So you're a hazard to yourself.
Yeah.
So therefore, with help from the police and crisis team, they're formed under the Mental Health Act, right? They're apprehended, they're brought to a hospital, they're forced to stay for evaluation. Depending on the outcome, likely they might get an extended stay until they can be put on medication, stabilized, and then hopefully sent back to. Lots of these people will go to work. Like, mental health affects everybody, right? And when you're able to manage it effectively with treatments, therapy, medications, you can live a normal, active, healthy life. But when things fail, you go off your meds, things change in life, people experience a crisis. And we don't let them decide not to get help when they're in a mental health crisis. We have legislation designed to force them to get help.
Yeah, right.
So how is it different when I sit in an alley and potentially kill myself 6, 8, 10 times a day? And all of a sudden, I'm going to come to you as a medic and say, you want to go into the hospital today? After I just woke you up from near death.
Yeah.
When you made the choice, and we'll do it again in about an hour. And I'm going to let you say, no, thanks. We'll see you next time.
Yeah. And addiction is a disease in its own.
Where's the line though? Like, I mean, when you have an addiction to drugs, there almost has to be some sort of mental health issue as well. And so you were just saying, Tony, that if someone has a mental health crisis, you're able to there's involuntary treatment that's enacted. But you're also now saying though that people that have these addictions, there's nothing for them. There's nothing that you can do. It's totally voluntary at this point, right? And so that, I think, is like a real shortfall on the system that needs to be fixed.
And again, I don't know any of this on any level other than just my own little brain
and that's
turning wheels. But
it's your experience.
I feel like if we did brand it as, a diagnosable mental health issue and form them under legislation, where are we going to put them?
Well,
we have no facilities available, from my understanding, to fill with these individuals, right? People are already on waiting spots for rehabilitation beds, right? And so if we have people voluntarily admitting themselves and having to wait, how are we going to now bypass with, if we apprehended everyone that overdosed, we would probably have 1,000 people Form 10 waiting for a bed tomorrow.
Right.
Right.
There's no actual facility.
But once we make it legislation, now we're required to, right?
Right.
So it's almost like, in my mind, you couldn't make that legislation until we had the ability to follow through and provide the care that we're mandating they take.
Where do you put them?
Right. So where do you put them?
Yeah, but I'll tell you, the numbers have been done. There's been case reports. Medicine Hat Alberta, they effectively ended homelessness of the drug opiate situation by housing first, full wraparound services, mental health supports, addiction supports. It actually saves you money in the long run. It's a matter of coordinating these things. We know the answers. They work. I mean, we've got Niganon housing here. We've got a lot of, for instance, they got full wraparound services, and from the most severe addicted drug, multiple overdose individuals that, a lot of mental health issues, from, maybe somebody on the other spectrum that just needs a helping hand, that, they lost their way. But the answers are there. And believe it or not, it actually is cheaper to house people than to leave them homeless in the long term.
Yeah.
And so it's just a matter of coordinating and legislating these things. The answers are there. We just need to do them. And we better do them fast, because I feel we're at a crossroads. I mean, if you look at the numbers from last year to this year, 207 opioid reversals on our transit system alone, when last year it was double that for the entire year, is telling us something. We're going in the wrong direction. And, it's almost like I don't want to hear these the answers that we can't, because we absolutely can, and we should.
There's a disconnect. One of the main problems is there's a major disconnect between the decision makers and the frontline workers. There's, you have people making decisions with no real world experiences and no real idea of what realistic, pragmatic solutions are, right? You got guys like Tony that are on the streets treating these problems with ideas and suggestions. And, they're falling on deaf ears. And to your point, you actually have communities and organizations that have figured out some solutions that are proven to work, right? Like in Medicine Hat and Naganon. Um, and yet nobody is doing anything about it. Nobody's looking really seriously into these solutions, and maybe making some suggestions to make some changes at the city level in Edmonton. So I think this is a real leadership problem here, right?
Absolutely. And as mayor, that's a thing that I want to aim for, housing first solutions. We got a lot of land, we've got a lot of vacant buildings, but you can't just give them the home. You got to have dignity involved. There's cultural items as well that you got to respect. There's issues of trauma, there's issues of abuse. And at the same time, you got to have a full wraparound services. We're not reinventing the wheel here. I mean, there are resources there. We're a resource-rich country. I don't like to hear we don't have enough resources. There's 40 million of us. At the federal level, even we've got a lot of wealth here, and the Commonwealth is less common than it used to be. And I think we really need to take care of one another, and we're all seeing the result of not.
Yeah, absolutely. And I think when we try and help produce some of these changes, there's always the percentage or the individuals who just won't accept the help, right?
That's right.
And we've seen it. And you can put them into programs, you put them to housing, and it works for a bit, and then they're back out, or they refuse it to begin with, or they don't follow through, or they damage the house you gave them, and you hear these stories as people's kind of defense against providing these resources, right?
Yeah,
you're always going to have people who don't want the help, right? There's always going to be those individuals. And there's always going to be ones who fail out of the program, and it's not going to be successful for them. But that doesn't mean we don't still do it.
That's right. Well, you're not going to save every tooth, right? You're not going to save every cancer. You're not going to save every mental health, but we still have to turn down the taps, and we still have to treat it as a disease and offer treatment.
Yeah.
I feel it's really, we're not really meeting the mark here in terms of offering our citizens and our Edmontonians here proper treatment for a lot of the mental health and addiction that they're under.
Absolutely, at all levels. Not just even mental health, and not just the at-risk houseless population. It's everyone in this city is at risk of not getting the help they need. We routinely hold 911 calls for service. Routinely. We used to have red alerts. I don't know if you've, in your research, remember those? Used to post them on social media when there's, 3 to 5 ambulances available, right? And then there's no ambulances available, and it's a red alert. Well, you haven't heard about them lately because rather than run out of ambulances, they hold calls.
Right.
So it's still the same thing, but they just don't want the red alert, right? So they hold calls for service.
Yeah.
And therefore we have an ambulance available, right? So the problem isn't fixed,
right?
They've just changed the way they manage it and report it to make it seem better. Even I'm curious what'll happen with overdose statistics because they have a new call determinant. When you look at dispatches on a 23 card, that's an overdose. But now they have a new dispatch determinant for if we go to help other resources. So if we go to help police at an overdose or another service, a downtown service, a resource, it comes in as a different determinant, even though 90% of them are overdoses. So the 23 cards, the overdose calls are going to go down. These other determinants are going to go up, but they're going to be less reported overdose responses.
And statistics is one of those things, the disconnect between real life, as Dr. Ye is saying, and actual real life solutions, right, to the problems that we face every day.
Yeah.
I mean, it goes back to, at the end of the day, it boils down to good leadership. And that's why I think that, it's a really good thing that you're running. And that's why, we are all supporting you running for mayor, because at the end of the day, there's certain qualities that make a good leader. And these qualities are lacking in the current political leaders, which are not lacking in you. We see all these qualities that Dr. Omar presents. Number one, integrity and accountability. You can't have one without the other, right? You have to get good moral standing, belief in what's right and what's wrong, and a vision, you need to have a vision, a clear direction of where you want to go, and something that inspires people to follow. You have to be decisive in terms of making the right choice and then acting on that. But then at the same time being accountable, right? And you have to be adaptable. So like, I mean, you've shown that, when the circumstances change, right, you adapt and then you find solutions which make yourself and everybody around you still successful, right, under more challenging circumstances. But when you're talking about leadership in public, public roles in government, there's one additional quality that you have to have, and that's altruism. Altruism makes you a good public servant, right? It's different than a leader. Like, if you're a leader of a company, a CEO that's profit driven and whatnot. But when you're part of like a public service organization, like a municipal government, you have to be there. There has to be altruism, which means, you're doing something that's good for others, but may not be good for you. And so that means there's a sacrifice. There's a personal sacrifice from your end. And, you've seen it, you've proven it. You're selling your practice, you're putting your life on hold, you're putting your family on hold so that you can run for mayor because you see a problem. There's lots of problems we talked about today, and there's like many, many more that that need to be dealt with. But you're basically making the ultimate sacrifice to run for mayor so that, hopefully you can make a difference. And, I just want to say publicly that I congratulate you for that, and you'll have my full support.
One of my longest term friends, and he knows, I've always been about service, and that lifelong beliefs, at least as far as I remember, that you always get far more back than you ever give. I've traveled a lot internationally to serve others because, it fulfills me a certain way. But, as of late, I've seen a lot of issues in Edmonton, here at home, that really need attention. I'm not one to stay quiet. But I think we're all people here of service, but by all means, dealing with healthcare at all different degrees. I mean, sir, I don't know if I could do your job for sure. I've heard tons and tons of stories, and you've been in the field for, was it 25 years now? So,
Yeah.
Do you carry a journal? Do you have a journal?
A mental one.
Mental one,
right?
yeah.
Which there was a delete button sometimes. But I hadn't met you before in person, and I was kind of impressed how when we started talking, you seemed to already have a fair bit of understanding around the problems. Even in the EMS world, I was surprised that most people don't understand on the level that you seemed to the problems with EMS.
Thank you.
And I think I was very impressed with that because it's encouraging to see that someone, even whether it was on an individual level or whatever prompted you to look into those issues, you knew them. I thought I was going to have to educate you on them, but you already knew. And it just felt good to see someone who's in a position to maybe one day, make some changes here. And you had already taken an interest and a concern in our welfare. You talked about our safety, right? Like no one really cares about a medic's safety, right? Call 911 when we show up, but you already had thought about it and looked into it. And so, I think it meant a lot. And I think as medics, on a whole, to know that someone, kind of in your position and running for mayor cares enough about what we're doing out there to investigate it on their own and to be concerned about it, I think it is great. So I appreciate that.
Awesome.
And thank you for that.
Oh, thank you.
And hopefully you remember us little people.
Of course. Well,
one day.
Edmonton's my home. I'm born here in Edmonton, 1978, man, I'm getting old. Misericordia Hospital looks exactly the same from the day I was born. We can do a throwback Thursday, just take my mom there. We don't even have to edit the background.
Yeah.
But for me, I've seen, a lot of things, change in Edmonton. I'm a proud Edmontonian. My soul belongs here. So I'm always driven by how to improve my home and improve others and bring everyone up. So, maybe that's my motivation behind it, but I'm always learning and growing. And one thing in life, the way I've accomplished, so many things in my life, and, one of these dominoes here is Dr. Alexander Ye. But I always surround myself with people that are better than me, right? Because we all are experts in our own right. You can't do it alone. But I believe true leadership and the way we're going to come together. And it's my slogan. It's time to shine. Let's shine brighter together. And that's the only way we actually shine is with groups and by surrounding ourselves with people that are better than us. Service is important as well. Living in going through life, I believe service is such an important thing, and I think we can all appreciate that. So, but gentlemen, our time is up. That is all the time we have for our show today. Thank you, Tony, for coming, and Dr. Ye, always a pleasure. Friend of 30 years, one of my oldest friends. I think maybe my oldest friend of all, actually. That's still stuck with me for 30 years. I guess I must be doing something right. But that's all the time we have for the show. Please help yourself to some cookies and sunglasses. And we always end the show with, it's time to shine, Edmonton. Let's shine brighter together.
The time has come. The time is now.
Good show, guys.
It's time. It's time to shine. It's time to shine, Edmonton. Let's shine together. Let's all shine bright in all kinds of weather. Time to shine, Edmonton. Let's shine together. Let's all shine bright in all kinds of weather. What? Time to shine, Edmonton. Let's shine together. Let's all shine bright